We have a patient with diabetes, and didn't get insulin injection. Of course, we know diabetes is what? Increase in what? Glucose level. And over here, the person having glucose level of what? 50 millimole per liter. And you know it's supposed to be 3.5 to about 5.5 millimole per liter. Now, this has led to what we call hyperglycemic coma. Hyperglycemic coma. And the question is, what mechanism is prevalent in the development of this coma? We've done a question like this before. So over here, even though there is too much sugar leading to coma, but the person has not yet developed what we call ketosis, or acidosis in the body. So over here, what comes to mind? We are thinking about hyperosmolarity. And the condition is called hyperosmolar hyperglycemic state. Hyperosmolar hyperglycemic state. And this is a complication of diabetes mellitus, whereby the sugar or the glucose are not well controlled. And another complication of too much sugar is what we call the ketoacidosis. But over here, there's nothing about ketoacidosis. So what is the mechanism here? Too much what? Sugar, called hyperosmolar. So over here, you can go in for hyperosmia. I think that they're trying to write hyperosmolar. That's the right way. Hyperosmolar, not hyperosmia. All right. Okay. So your answer should be what? Should be C. We have necrosis focus, which appeared in the area of hyperemia. When we say hyperemia, too much what? Blood at that area. So the place becomes what? Reddish. And skin edema. Again, we are having what? Edema. That means accumulation of fluid at that area. In few hours after a burn. What mechanism strengthens destructive events in the inflammation area? So obviously, there is what? A problem with what? With microcirculation. Why? As a result of the burn. So what type of mechanism are we talking about? So over here, you need to understand that when we talk about primary alteration and secondary alteration, we are talking about what? The change in the microcirculation. When we talk about microcirculation, we talk about the blood. We're talking about the tissues over there, where they could increase in permeability of the vessels and stuff like that. So there'll be movement of substances here and there. That's what happens. Okay. Now, the fundamental difference, let's kindly mute our microphone if your microphone is on. Dr. Kwesi, your microphone is on. Great. Thank you. All right. So the fundamental difference is that secondary alteration is caused by inflammatory mediators. Now, primary alteration is caused by pyogenic agents, such as maybe bacteria and other stuff. It can also be caused by viruses and even high temperatures, such as frostbite. Again, when we're talking about primary alteration, we are talking about what? An agent that is actually what? Going to lead to secondary alteration. So primary means an antigen, quote and unquote. It can mean what? An antigen. So when an antigen comes to the body, the first reaction, we call it the primary what? Alteration. Now, when it starts reacting, that's when secondary alteration comes to play, whereby there will be introduction of what? Inflammatory mediators, such as macrophages, neutrophils, interleukins, and so on and so forth, and so on and so forth. So what is actually leading to the hyperemia and then the skin edema formation is because there is an inflammatory process taking place at that area. There is an inflammatory process taking place at that area. And so therefore, the mechanism for this inflammation is called secondary alteration. Secondary alteration. Secondary alteration. All right. Now, the processes of repolarization are disturbed in particular myocardium in an examined person. It causes amplitude abnormalities of configuration and duration of the wave. The question is, which one of these waves has to do with repolarization? Repolarization. Now, on ECG, you must know that the T waves represent the repolarization of the ventricles. The repolarization of the ventricle. When we say repolarization, we are referring to what? Kind of the relaxation of the ventricles. The relaxation of the ventricles. So just know that T waves represent repolarization. Repolarization. So over here, we are talking about the T wave. The T wave. The T wave. All right. Now don't forget the P wave represents what? Atrial contraction or atrial contraction or depolarization. That's the P wave. P wave. And the KRS is also referring to what? The ventricles. The ventricles. The ventricles. So please take note of these simple things. Okay. Now we're having on a simulation of inflammation of the lower extremities. The animal experience raise of temperature, increased amount of antibodies and leukocytes in the blood. The substances cause this reaction of the organism. Sorry, what substances cause this general reaction of the organism on inflammation? On inflammation. Again, this could work. Secondary alteration by what I just said earlier on. This is what? Secondary alteration. And we said in secondary alteration, we are thinking about what? Inflammatory mediators. Inflammatory mediators. And if you look at the options here, which one of them is an inflammatory mediator? Or which one of them is a cytokine? And again, you are looking at for what? Interleukin. 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 So your answer is what? Is A. Interleukin. And specifically, interleukin 1 is responsible for the rise in temperature. Again, interleukin 1 is always responsible for rise in temperatures. So take note of that. Interleukin 1. Interleukin 1. Interleukin 1. All right. So your answer here is E. Oh. What happened? Oh. So you're going to see the answer, but then let's look at it. A patient with hypertension has developed headache, tinnitus, vomiting, and high blood pressure up to 220 and 160. This is extremely high. Extremely high. Now, on facial asymmetry, on the right, there is what? Volitional mobility is absent, increased tendon reflexes and muscle tone of extremities on the right. The motor disorder of the nervous system occurred in this what? Case. So, what are we looking for? What are we looking for? And we know that if you have too much hypertension or too much high blood pressure, it can lead to CNS damage or it can lead to stroke. Stroke. So one of the risk factors for development of stroke is what? Is hypertension. It's hypertension. And stroke can mean half of your body or even the whole body can develop or can be paralyzed. The whole body can be paralyzed. But if you look at this patient, it is what? Asymmetrical. When we say asymmetrical, it means it's occurring at one side of the body. One side. If you say symmetrical, that means it's occurring on both sides of the body. But over here, we are talking about one side. So we call it hemiplegia, hemiplegia, hemiplegia. So basically, that is it, hemiplegia. All right. Now, if we say volitional mobility is absent, we are referring to inability to make what? A choice or to make decisions. Inability to make a choice or inability to make a decision. And all these things are what? Absent. So again, we are talking about hemiplegia, hemiplegia. Okay. Which refers to the total or partial paralysis of one side of the body. One side of the body. Of course, due to brain injury. All right. After a serious psycho-emotional stress, a 45-year-old patient suddenly felt constricting heart pain. Guys, constricting heart pain. We were dealing to the left arm. So over here, you are thinking of what? Angina. Angina, heart pain, angina, angina. It radiates to the left arm, the neck, and even the left scapula. His face has turned blue, has turned pale, cold sweat stood out. The pain attack was stopped. Guys, if you remember the pharmacology, we said if someone is suffering from uh, angina, you can give the person what? Nitroglycerin. Nitroglycerin. These are nitrates. These are organic nitrates. So we give them organic nitrate. And over here, they give the person what? Nitroglycerin. So again, it goes on to confirm that this person has what? Angina. Angina. Another name for angina is stenocardia. 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 Another name for angina is stenocardia. Stenocardia. So here, you are thinking of what? Of A. All right. Periodic renal colics attacks are observed in the woman with primary hyper or hyperparathyroidism. Parathyroidism. And we'll talk about parathyroidism. We're actually referring to what? To calcium. 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 Of course, the thyroid hormone will also be affected. But mainly, we're also thinking of what? Calcium. Calcium. Now, the ultrasonic examination reveals small stones. Again, it goes on to confirm that calcium can lead to what? Kidney stones. It can lead to kidney stones. Kidney stones. Kidney stones. So, what is the cause of the formation of the stones? Of course, too much calcium in the body. Too much calcium in the body. And we call it what? Hypercalcemia. 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 All right. Now, while having the dinner, the child got choked and aspirated the food. Okay. Heavy cough has started. Skin and the mucus are cyanotic. That means they are blue. That means they don't have difficulty to even breathe, right? Because they are blue. No oxygen is there, so it's blue. Rapid pause, rare breathing. Look at this. Expiration is prolonged. Expiration is prolonged. What disorder of the external breathing developed in this child? Of course, the person was aspirated a food. So we call it what? Asphyxia. 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 So this can lead to what? A block for patient to receive what? Oxygen. So asphyxia actually refers to a condition of deficient supply of oxygen to the body that arises from abnormal breathing. Arises from abnormal breathing. So when food is taken in, passes through where it's not supposed to pass through, it can cause what? Blockage of the respiratory system, causing abnormal breathing, and of course, deficient in oxygen supply to the lungs. So basically, that's what happens. Now, this person is experiencing what? Prolonged expiration. Prolonged expiration. So, this is expiratory dyspnea. Dyspnea simply means difficulty in breathing. Difficulty in breathing. So, this is what? Stage of expiratory dyspnea on asphyxia. Stage of expiratory dyspnea on asphyxia. On asphyxia. Why? Because the person has a labored expiratory phase. Labored expiratory phase. So the answer is A. Is A. It's A. All right. We have a chronic glomerulonephritis. Chronic. Anytime you see chronic problem, definitely you are going to see a complication also happening in the patient, right? Which is what? Kidney failure. There could be a kidney failure present. So everything here is connected to what? Glomerulonephritis. So chronic glomerulonephritis was diagnosed in a 34-year-old patient 3 years ago. Look at this. Edema has developed in the last 6 months. What caused it? What is the cause of edema? Then again, someone asked a question before the lecture that what is really the pathogenesis for edema formation? What is really the pathogenesis for edema formation? So you can write this down. This is not the question I want to use to explain, but let me use this one to explain. Then when we get to that question easily, you understand it. So write this down. One. We have what we call oncotic pressure or vascular oncotic pressure. Vascular oncotic pressure. Vascular, that means oncotic pressure in the vessels. And this is controlled by protein. To be specific, albumin. That's what oncotic pressure in the vessel. Oncotic pressure in the vessel. That's one. Two, we have hydrostatic pressure. Hydrostatic pressure. When we say hydrostatic pressure, it talks about what? The volume of fluid. Or pressure that's caused by volume of fluid. That's that's the hydrostatic pressure. Then you can think of vascular permeability. Permeability of the vessels, technically. Permeability of the vessels. So these are the three main mechanisms or three means by which edema can be formed. So now, when we talk about the oncotic pressure, like I said, it is controlled by what? By albumin or proteins. Now, when there is less amount of protein in the vessel, we said the person has developed what? Decreased oncotic pressure, which means that the oncotic pressure outside the vessel is high. It means that the oncotic pressure outside the vessel is high. And by osmosis, fluid will move from low concentration of solute. Don't forget, proteins are solutes. Fluid will move from low concentration of solute to a high concentration of what? Of solute. So that means that fluid will move from the vessels into the interstitium or the extracellular matrix. So it means that fluid in the outside the vessels will become what? Big. So edema will be formed. So that's how oncotic pressure plays in the formation of what? Edema. So that is one. Now apart from proteins, which I said they are solute, sodium are also solute. Yes, and sodium also draws what? Also pulls water. So imagine the vessel has a lot of sodium. It means that more water will come into the vessel, thereby increasing the pressure in the vessel. That's what we normally call the hypertension. And yesterday we discussed something about the renin-angiotensin system, where aldosterone will lead to the production of what? Sodium, or to retain sodium. Okay, but let me not mix the whole thing up for you. So for now, think of the proteins as the oncotic pressure. So when there's low protein in the vessel, fluid will leak out of the vessel into the interstitium. Good. Now, I mentioned about hydrostatic pressure. Hydrostatic pressure. Now, when there's too much or when there's high hydrostatic pressure in the vessel, it means that edema will develop in the vessel. But edema formation in the vessel is called hypertension. When there's edema in the vessel, we call it what? Hypertension or high blood pressure, because too much pressure is there, too much volume is there. However, when there is no volume or too much volume in the vessel, but rather outside the vessel, we call it what? Edema. Edema has developed. Edema has developed, which means that the pressure in the vessel is low. So when you have low hydrostatic pressure, it means that edema can be formed. Low hydrostatic pressure, meaning the volume in the vessel is less. So pressure will be in the outside the vessels. That's another mechanism. Then the last one, I'll talk about what? Permeability of the vessels. Permeability of the vessels. When we say permeability, it's the ability of the vessel to allow substances to pass through it. The ability of a vessel to allow substance to pass through it. So when we say something is highly permeable, it means that more substances can pass through. When we say it is less permeable, meaning that not all substances can pass through. Now, when we have a destruction of the vascular system, the vessels become what? Highly permeable to water and to other substances. So, for example, when there's inflammation process taking place, the vessels become weak or they become highly permeable. So, substance will immediately move from the vessel into the interstitium, and that can cause what? Edema. That can cause what? Edema. So these are the main mechanisms of what? Edema formation. Of course, we can talk about other things like I was mentioning the renin-angiotensin system. Okay, another one you can think of is vasopressin system, the vasopressin system, or antidiuretic hormones. They can all come in handy to play a role in edema formation. So for now, I've laid the foundation for you on edema formation. Now let's start solving questions on it, and then let's see if we can apply all of these things. Great. So we are saying that we have a chronic glomerulonephritis was diagnosed in a 34-year-old patient. Again, when there's chronic glomerulonephritis, it means there's a problem with the kidney. So the kidney can become what? Damaged, and more substances can easily leak out. So many things can easily leak out. And they said, look, edema has developed. And in glomerulonephritis, what happens? The glomerulus become permeable to proteins. Because I said one of the cause of edema formation is what? It's proteins or albumin. So when you have a problem with the kidney and more proteins are being leaked out, what happens? It means that what? Hypoalbuminemia or low albumin in the blood. And when there's low albumin in the blood as established, there'll be what? Edema in the interstitial tissue or in the interstitium. The word edema formation. So over here, we can easily say that this person has what? Proteinuria. I hope we are clear on this now. All right. Proteinuria. However, if you are still lost, please, at the end of the discussion, please draw my attention and I'll take my time to explain to you. All right. Good. We're saying while playing volleyball, a sportsman made a jump and landed on his outside edge of his foot. He felt acute pain in the talocrural joint. Active movements are limited. Passive movements are unlimited but painful. A bit later, there appeared swelling. Swelling means what? Inflammatory process or edema formation, right? Edema formation. And I said One of the ways of developing edema is what? When we're having what? A micro circulatory what? Problem or permeability of the what? The vessel. Permeability of the vessel. And I said permeability of the vessel can occur when we have what? Inflammatory process. Inflammatory process. So now look at it. It said at the external ankle, the skin became red and warm. Skin became red and warm. What does it mean? It means there was increased flow of fluid or blood into that area. Increased flow. Increased what? Flow. So what comes to mind? You are thinking of what? Hyperemia. 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 And this is arterial hyperemia. Arterial hyperemia. And it is characterized by increase in blood supply of the organ or tissue due to increase in blood flow through the arterial vessels. Through the arterial vessels. Through the arterial vessels. Now, in venous hyperemia, there's always congestion. Always congestion. And usually it is cold to touch. Again, it is cold to touch. But in arterial hyperemia, it is warm or hot to touch. So please take note about the difference between what? Venous hyperemia and arterial hyperemia. One causes what? Congestion. And of course, it also means what? Swelling anyways. But it is cold to touch. Whilst arterial hyperemia is what? Warm to touch. Warm to touch. So please, these are your clues. These are your clues. So here we are thinking of arterial hyperemia. Having helped to eliminate consequences of a failure of a nuclear power plant, again, yesterday we talked about what? Radiation. We talked about radiation, and we said in radiation, all the cells will be affected. All the cells will be what? Affected. All the cells will be what? Affected. Good. However, which one is affected the most? Is the lymphocytes. Lymphocytes are affected what? The most, or they are the first to be what? Affected, to be destroyed. Good. Now they said after a failure to eliminate the consequences of a nuclear power plant, a worker got an irradiation dose of 500 units. He complains of headache, nausea, dizziness. What changes in the leukocyte quantity can be expected 10 hours after the irradiation? 10 hours after the irradiation. So first of all, the nuclear radiation will produce what? An inflammatory reaction in the patient. It will produce an inflammatory what? Reaction in the patient. And neutrophils are the first leukocytes that cross the blood vessel wall to enter the inflammatory site. Leukocytes are the first people to enter the inflammatory site. And I said this one when we talk about, we talked something about that before. And I said what? Neutrophils are the first people to go. And this is followed by what? Macrophages and then lymphocytes. Followed by macrophages or monocytes, and then thirdly, followed by lymphocytes. Followed by lymphocytes. Over here, we are looking at what? A neutrophilic leukocytosis. Neutrophilic leukocytosis. All right. We have a 12-year-old boy suffering from what? Bronchial asthma. Bronchial asthma. First of all, you must know that bronchial asthma is what? An obstructive disease. Obstructive. So even if you don't know, you know that bronchial asthma is what? Obstructive. Obstructive. Has an attack of asthma. There's evidence of what? You see, expiratory dyspnea. That means there is you remember choking? Yes, we'll talk about choking in 4 or 5 slides before this one. Choking is what? Also what? An obstruction. Okay. And the skin pallor, what type of alveolar variation? Again, you are thinking of what? obstruction. So this is obstructive, obstructive. So the answer is C, obstructive, obstructive, obstructive. Okay. Now in restrictive, you could be thinking of cystic fibrosis. You could be thinking of what? Cystic fibrosis as well. Cystic fibrosis. Yeah. No. Cystic fibrosis is also obstructive. Sorry. Cystic fibrosis will also be obstructive because the ciliary will not be able to clear the substances that have been accumulated or the mucus that have been accumulated. So that one is also called obstructive. It will also cause obstructive. It will also cause obstructive. So that one also be obstructive, not restrictive. But in restrictive, normally you have to do with the lining inside the lungs. It has to do with the lining inside the lungs, inside the lungs. All right, good. We have what? A 46-year-old patient suffering from diffuse toxic goiter. Diffuse toxic. That means there's what? Hyperthyroidism. When we say toxic, it means that there are signs and symptoms of what? Hyperthyroidism. Hyperthyroidism. That means too much of thyroid is found in the blood. And he underwent recession. Okay. Now, after surgery, the patient presents with appetite loss, dyspepsia, increase in neuromuscular excitement. The body weight remained unchanged. Temperature is normal. Which of the following can cause such things? Which of the following can cause such things? Don't forget the person has undergone what we call thyroidectomy, or the removal of the thyroid is called what? Thyroidectomy. 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 And one of the complications of thyroidectomy is that it can affect the parathyroid gland as well. So you can have what? Hypoparathyroidism. 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 So therefore, over here, what can be the cause? We are thinking of a decrease in the parathyroid hormone. And so therefore, your answer should be what? A reduced production of parathyroid hormone. A reduced production of parathyroid hormone. All right. So your answer should be what? Should be A. Of course, there also be reduced thyroxine because it's also what hormone produced from the thyroid. Okay, but over here, our major focus will be what? The parathyroid hormone. And again, we are talking about neuromuscular excitement. Neuromuscular excitement. And calcium can play a very big role in all those areas. All right. To prevent transplant rejection, again, we have done something about transplant rejection in, I think, pharmacology also. There was organ transplantation. An organ transplantation is required to administer hormone therapy for the purpose of immune suppression. Immune suppression. What hormone can be used? We talk about it. You need an immunosuppressant, and the immunosuppressant is always what? Glucocorticoid. To be specific, prednisolone. Prednisolone. So here we are thinking of what? Glucocorticoid. 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 All right. A patient caught a cold after which there appeared facial expression disorder. He cannot close his eyes, raise his eyebrow, bare his teeth. What nerve is damaged? What nerve is damaged? In fact, they've already told you the answer. Students have what? Facial expression disorder. And facial expression are normally controlled by what? By the facial nerve. Is facial nerve or the seventh cranial nerve. They control the muscles of the facial expression. They control muscles of facial expression and also function in taste sensations from the anterior to thirds of the tongue. Anterior to thirds of the tongue. So over here, we are thinking of what? Facial nerve. Facial nerve. Facial nerve. All right. Wow. I like a question when I see acidosis and alkalosis. I love it. And yesterday, we took our time to discuss something like that. Now, a group of mountain climbers went through the blood analysis at the height of 3,000 meters. Now, it revealed a decrease of bicarbonate. There is decrease of what? Bicarbonate to 15. The standard is 22. What is the mechanism of bicarbonate decrease? What is the mechanism of bicarbonate decrease? Bicarbonate decrease. So over here, if you are climbing these kind of heights, you are breathing a lot. So you are what? Over breathing. Over what? Breathing. And it's called what? Hyperventilation. Hyperventilation. And why do you overbreathe? You're overbreathing because you want to get rid of what? Carbon dioxide. You want to eliminate carbon dioxide. And don't forget, the more you climb up, the more there's a reduced oxygen. The more you are climbing up, oxygen level concentration was decreases. And so therefore, more carbon dioxide will be built up. So you begin to breathe just to get rid of all the acid out of your system or all the bicarbonate out of your system. So what you're talking about hyperventilation, hyperventilation or overbreathing, 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 overbreathing. So it will reduce what? The concentration of carbon dioxide in the blood. To reduce it in the blood. So when that happens, what kind of acid-base balance will you get? What kind of acid-base balance will you get? What kind of acid-base balance will you be getting? So definitely, since you are breathing in plenty and you want to bring in more oxygen, you will start developing what? Alkalosis. And we'll talk about it. In hypoventilation, we develop what? Acidosis. And then in hyperventilation, we develop what? Alkalosis. We develop alkalosis. So over here, you are thinking of what? Hyperventilation. 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 All right. So the answer is A. Now, ECG of a patient shows such changes or alterations. P wave is normal. PQ interval is short. PQ interval is short. And yesterday we discussed that when we talk about the PQ interval, we are referring to what? To the AV node or the atrioventricular node, whereby the impulses that are coming from the atrium will actually what? Have a short period, adjust itself, and then fire, isn't it? So they're saying that that period is very short. It's very short. That means that something is there that is not allowing the AV to perform what? Its function normally. So it's flowing faster than normal. Now, ventricular KRS complexes is wide, and the R wave is double peaked or two-phased. What form of arrhythmia has developed? What form of arrhythmia has developed? And over here, we are having an extra electrical pathway in the heart. We are having an extra electrical pathway in the heart. Like I said earlier on, why is it that we're having a short PQ interval? It's because what? There's a problem with the AV node. It is not blockage. So I'm not going to say this is atrioventricular blockage. It is not blocked. If it is blocked, it means that the PQ interval will be delayed. It will be what? Delayed. But it is not blockage. So you can't think of what? Delaying. So it means that there's another thing, electrical pathway somewhere else that is causing this short PQ interval. This short PQ interval. And that phenomenon, we call it Wolff-Parkinson-White. That phenomenon, we call it Wolff-Parkinson-White. And then the R wave will be always what? 2, but the R wave is going to be 1. You know, the long, on the ECG, when you have the P wave like this, okay, then you have the something like this. Good. So you see, this is your R wave. Okay, this is your R wave. Your R wave. Now, over here, they're having what? Two waves. So it's like this. Before it now come down. And that is not right. It's not supposed to be so. And again, the QRST is also what widened. So the this is Q, QRST complex is also what? Too wide. That tell you that there is what? A problem. And that is called what? Wolf Parkinson White. Wolf Parkinson White. So here, your answer would be what? Will be A. Wolf Parkinson what? White. Wolf Parkinson White. All right. A patient who suffers from pneumonia has high body temperature, of course. Now, look at it. What biologically active substance plays the leading part in the origin of this phenomenon? They are talking about what? High body temperature. And they are saying what substance causes high blood pressure, high body temperature. And I said it. This is interleukin 1. Interleukin 1. I said it. So please take note of that. Interleukin 1. So your answer is D. A 34-year-old woman was diagnosed with hereditary microcytic hemolytic anemia. Okay. What mechanism causes hemolysis of the erythrocyte? Oh, the only thing that there's a problem with what? With the shape of the erythrocyte. Erythrocyte is always what? Biconcave, right? It's always what? Biconcave. But now they have what? A spherocytic hemolytic anemia. That means it's what? Spherical in shape. And that is not the normal size or the normal shape of the RBCs or erythrocyte. So this one we're having what? A membrane problem. So this is what? Membranopathy. A membranopathy is the membrane that has been what? Affected. So this is what? A membranopathy. Membranopathy. All right. Now, from the group of children who were eating sweet, sappy watermelon, 2 kids developed signs of poisoning. There are signs of poisoning: rapid weakness, dizziness, headache, vomiting, edema, tachycardia, cyanosis, blah, 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 blah. Now, look at it. There is high concentration of nitrate. High concentration of what? Nitrate. What is the leading mechanism of the pathogenesis of the poisoning in the 2 children? Again, there's what? Cyanosis. And the presence of cyanosis simply means that what? The body is lacking what? Oxygen. The body is lacking oxygen. Or the blood is not able to bind with oxygen properly. And you know that what controls the binding between oxygen and blood? It is the hem or hemoglobin. So hemoglobin is the factor that has to work combine with what? With the oxygen to prevent what? Cyanosis. To prevent cyanosis. But this place, we are lacking that ability. And so therefore, and look at it, the nitrate can also block such things. Too much of nitrate happening. So the nitrate can prevent cyanosis. And that mechanism, we call it methemoglobin. Methemoglobin. And of course, the enzyme responsible for converting the methemoglobin to the hemoglobin is called NADH, methemoglobin reductase. NADH, methemoglobin reductase, MET, hemoglobin reductase. Over here, we are looking at for what? Insufficiency of HB or hemoglobin reductase. All right. We have 2 years ago, a patient underwent recession of pyloric part of the stomach. Again, anytime you see a problem, either there's a disease or there's a condition that happened, always look at what? The complication of such phenomenon. Complication. So we're going to look at the complication of what? The recession of the pyloric part of the stomach. a complication. So now he complains of what? He complains of weakness, periodical dark shadows beneath his eyes, dyspnea, hemoglobin is 70, erythrocyte, color index is low. Color index is low. What changes of erythrocyte in the blood smear are the most typical for this? Now, again, don't forget that recession of the pyloric part of the stomach will lead to what? A decrease in gastric acid levels. It will lead to a decrease in gastric acid level. And aside that, we also said that there is how do you call it? These intrinsic factors also present. Intrinsic factors are all present in the stomach. So when all these fats are cut off, intrinsic factors also what? Be affected. And you know intrinsic factors for what? Absorption of what? Vitamin B12. Vitamin B12. So not only that will be affected, also iron absorption will be impaired. Iron absorption will be what? Will be impaired. Iron absorption will be impaired. And you know that iron is needed for hemoglobin synthesis. Iron is needed for hemoglobin what? Synthesis. And I always tell you that anytime you are seeing a color index that is low than normal, then you are thinking of a problem relating to the what? To the hemoglobin. You are thinking of a problem relating to the what? Hemoglobin. And again, hemoglobin can become more active and vibrant in the presence of what? Of iron. In the presence of iron. So in this case, we are having iron deficiency what? Anemia. Iron deficiency what? Anemia. Iron deficiency what? Anemia. So in addition to this, like I said, there will be what? Decreased vitamin B12 what? Vitamin B12 absorption will be what? Will be decreased too. And when the vitamin B12 also what? Decrease, what it means that cells are not able what? To function what? Well. Cells won't be able to what? To function very well. So over here, we are looking at what? Microcytic what? Anemia. Microcytic anemia. Because the RBCs will become smaller than normal as well. RBCs become smaller than normal. So here, we are looking at for microcytes or microcytic anemia. Microcytic anemia. Why? Again, because of what? Reduced iron concentration. Reduce iron concentration. Reduce iron concentration. So here you are taking more of what? Microcytic anemia. Microcytic anemia. Microcytic anemia. All right. As a result of a prophylactic medical examination, a 7-year-old boy was diagnosed with Nihand syndrome. And look, they said only boys fall ill with this. Only boys. Only boys. Only boys. Okay. Now, the boy's parents are healthy, but his grandfather, by the mother's side, suffers from the same what? Disease. Again, it affects only boys. Yesterday, I made a diagram describing all these genotypes and the alleles and stuff like that to you guys. Now look at it. The boy's parents are healthy. That means there's nothing wrong with the father. Because if it was to be boys only, that means the father should have had it, right? Or if it was to be the parents who have transferred it, that means the father should have had it. But the father is not having it. That means the problem is not the man. The problem is the woman. So that means that this woman could be normal, but could be what? Carrying the allele or the gene for this Lesch-Nyhan syndrome. And so therefore, this is what? Recessive. It's a recessive gene. It is what? A recessive gene. A recessive gene. So it is found on the what? Now, this can be found on the X chromosome. The X chromosome. The X chromosome. Because if the mother is a carrier, that means the mother will not have it, but only be carrying it. So the only way that the boy will have it is that the mother's X with the recessive gene on it has transferred it to the what? To the son. The son, as simple as ABCD. So this you are thinking of what? Recessive sex linked. Recessive sex linked. But we also call this a recessive X linked. Recessive X linked. X linked. X linked. All right. So this is A. I love this. I think this one you guys know it already. 27-year-old put on drops of what? That contained penicillin. I think we saw this yesterday. Few minutes later, she felt itching, burning of her body decreased. There appeared lip and eyelid edema, pressure. What immunoglobulin took part, and we said this is what type 1 hypersensitivity what reaction. This is anaphylaxis. And don't forget, it occurred few minutes after the use of the penicillin. After the use of the penicillin. I think in that question, they said they want to do a sensitivity test. But you see, the same thing. So over here, you are thinking of what? IgE and then what? IgG. IgE and then IgG. IgG. All right. Yesterday, I explained all the various types of immunoglobulins. So please, if you don't know this, kindly watch the video of yesterday. Watch the video of yesterday. All right. Inflammation of the patient's eye was accompanied by accumulation of tepid liquid with high protein at the bottom of the anterior chamber. That was called hypopemia. What process underlines such changes under observation? Again. What is happening? There is what? Inflammation reaction. And as a result of the inflammation, there's accumulation of a tepid liquid with high protein at the bottom of the what? Anterior chamber. But we're not supposed to have this inside the anterior what? Chamber. So what it means is that there is a problem with what? Microcirculation, or there is what? Hyper, or there's high permeability of the vessels. High permeability of the vessels. So this place is developing edema. Edema is developing in the anterior what? Chamber. Edema is what? Developing in the anterior what? Chamber as a result of what? The inflammatory what? Reaction. And again, I said in inflammatory reaction, we are having what? A problem with microcirculation. A problem with microcirculation. So here, you are thinking of what? Disturbance of microcirculation. Disturbance of microcirculation. Microcirculation. All right. Good. A 48-year-old patient was admitted to the hospital with complaints of weakness, irritability, sleep disturbance. Objectively, the skin sclera are yellow. That means there's jaundice. There is a conjugated bilirubin. Guys, look, conjugated bilirubin. Feces are acholic. That means it is colorless. It is colorless. And again, I remember we spoke about the difference between what an obstructive jaundice, or we have a conjugated jaundice and unconjugated what? Jaundice. We said in conjugated jaundice, the feces are always what? Colorless, or it's colorless, or white, or pale. It's colorless. Acholic means there's no color. There's no what? Color. So again, if something has been conjugated, okay, and we are having jaundice, we now refer to it as what? An obstructive form of what? Jaundice. Obstructive form of what? Jaundice. Again, we have about 3 types of jaundice. We have prehepatic jaundice, also known as what? Hemolytic jaundice. We have what? Hepatic jaundice, and we have obstructive or post-hepatic jaundice. So this is referring to what? Hepatic jaundice, also known as mechanic or obstructive jaundice. So here you are thinking of what? Mechanic. All right. A patient who suffers from severe disorder of water salt metabolism experience cardiac arrest in diastole. What is the most probable mechanism of cardiac arrest? What is the most probable of the cardiac arrest? And we know that the electrolyte that has to do with the heart. I repeat, the electrolyte that has to do with the heart. That's what we always monitor. Is what? Potassium. Take note. Potassium. And don't forget, in diastole, we are talking about what? The T wave. We are talking about what? The T wave. And the T wave deals with what? With potassium levels. So when there's too much of the potassium, what can happen? It can lead to what? Cardiac arrest. It can lead to what? Cardiac arrest. So here we are looking at what? Hyper or hyper. So severe hyperkalemia will cause the heart to stop in diastole. And again, there will be what? A peak T wave. Due to what? Accelerated repolarization of the cardiac muscles. So here we are talking about hyperkalemia. So the answer is B. Aha. Again, Dr. Lucy, this is a question on edema. They say a patient who suffers from heart failure has developed an enlarged liver, edemata of the lower extremities, and ascites. Heart failure deals with what? Deals with blood. It deals with what? With blood. So it has led to what? Enlargement of the liver. There's edemata of the lower extremity and ascites. What it means is that the blood has what? Accumulating in all these areas, and they are not going back into the heart for it to be used and come back again. Okay, so what it means is that there is what? Too much of volume in the interstitium. Because ascites has to do with the abdominal cavity. Okay, that's what the abdominal cavity. So again, you are taking about hydrostatic pressure, not oncotic, but rather what? Hydrostatic pressure. So again, what comes to mind? Hydrodynamic. So that's the mechanism. Hydrodynamic. I've already spoken about the oncotic pressure, also known as the colloidal osmotic pressure. Some books use colloidal osmotic pressure or oncotic pressure. Then we'll talk about the membrogenic. We're talking about what? The microcirculation, whether there's increase in permeability or not. That's what we talk about the membranes. Then in lymphogenic, we're talking about the lymph. There's a problem with, let's say we have lymphadenopathy. Problem with what? Lymphatic drainage can also lead to what? Edema formation. But over here, we are thinking of what? Fluid, because heart has failed. So the fluid, blood. So here is B. All right. Good. We have 2 weeks after lacunar tonsillitis. Again, when you have tonsillitis, we may mention that what can be affected. Kidney can be affected if it is not treated properly, or rheumatic fever can ensue if it is not treated properly. Again, since they mentioned tonsillitis, we are going to look at a complication of the tonsillitis, right? So now let's do. 2 weeks after the lacunar tonsillitis, a 20-year-old man started complaining about general weakness, lower eyelid edemata. Okay, after examining, the patient was diagnosed, guys, you see, acute glomerulonephritis. So this is actually what? Post-streptococcal glomerulonephritis. glomerulonephritis, post-streptococcal glomerulonephritis. That means there's a problem with what? With the kidney. And again, they said edema has been what? Been formed. What it means is that there is low amount of what? Proteins. Low amount of what? So that oncotic what? Pressure has decreased. That's why there's edema formation. So you see, over here, what comes to mind? Proteins. So proteinuria. Proteins are being excreted. So there's hypoalbuminemia or hypoproteinemia. So your answer is what? Is A. We have a 32-year-old man who is tall. He has gynecomastia, adult woman pattern of hair distribution, okay, high voice, mental deficiency, sterility, diagnosed with Klinefelter's syndrome. This person is having what? Klinefelter's syndrome. Don't worry. I'll come to all these Edwards, Patau, Klinefelter, Turner syndrome. I'll come to those ones later. So don't worry about this one. So we'll talk about it later. But definitely it's what? A chromosome what? Problem. Chromosomal what? Problem. You say in order to specify the diagnosis, what do you do? How do you analyze this thing? So you need to look at for what? The karyotype. In other words, the chromosome count. Chromosome what? Count. And in chromosome count, we deal with what? What we call karyotype. Karyotype. So karyotype simply describes the chromosome count of an organism and what these chromosomes look like under a light microscope. What they look like under a light microscope. Some people have XXY, XXY, XXX. You see, some people have OX. All of these things, we're able to know this one from karyotype, from karyotype, from karyotype. This is different from the genotype, where we are having all those things. Okay, so don't say, of course, genotype also look at it as well, but then mainly we are talking about the karyotype. We are thinking of karyotype. So over here, we're going forward for D. For D. All right. Okay. Examination of a minor, somebody who minds. There's what? Pulmonary what? Fibrosis. Pulmonary fibrosis. Accompanied by what? Disturbed alveolar ventilation. So what is the main? I think I wanted to mention this pulmonary fibrosis when we're talking about the obstructive and the restrictive pulmonary diseases. So this is actually what? Restrictive. Restrictive, because the heart will not be able what? To, it will not be able to pump or recoil. Sorry, expand and then recoil. When we say expand, when you breathe in, your lungs supposed to expand. Then recoil, when you want to breathe out, to recoil to bring it out. So when you have fibrosis, there is difficulties in such things. There will be difficulties in such things. So over here, we are looking at what? A limitation of the respiratory surface of the lungs. So your answer should be what? A. So pulmonary fibrosis, this is what? Scarring of the lungs. So when the lungs are scarring or undergoing fibrosis, what it means is that they lose their functionality. They will lose their functionality.